Thanks a lot. Now we will move on to our next session, and I want to call upon stage to chair this web lecture of Dr. Bernhard Meyer. So the chairpersons are Dr. Ashok Dhar, Dr. Anil Mishra, Dr. Dhiman Kahali.
Dr. Bernhard Meyer will be delivering the lecture on 4 decades of PTCA. Ladies and gentlemen, one should be always careful while having the job to introduce Professor Bernhard Meyer of University of Bern, Switzerland. Between the last opportunity to introduce him and today, quite a few new laurels have found places on his cap. Being myself a product of German and French-speaking part of Europe, I shall state a fact, having no doubt about it. Starting from late 70s of the previous century, when he wrote and signed the discharge summary of the first patient of the world who had his PTCA in Zurich, and Bernie Meyer was young assistant to Professor Kreinbuhl of Zurich in cardiology. The case was performed by Dr. Andreas Grünzig, assisted by Bernie, didn't have but any signature of Andreas because he belonged to the Department of Radiology. When we sit here to know about the 40 years of PTCA, we could have better knowledge about, who could have better knowledge about this, about it than Bernie. We are grateful to him for sharing his experience on the subject, and the cardiologists of Kolkata, where he personally participated at ICON meeting a few years back, I believe in 2014. Dear Bernie, cardios of Calcutta know you and love you. Please start your lecture and enlighten the audience present today.
Thank you, Ashok Dhar, dear Dr. Misha Bahali. I also thank, of course, Drs. Roy Mandal, who orchestrated this opportunity for me to give you a lecture from far away, from Bern, Switzerland, where you, as you can probably already see on your screen, winter has already kicked in. I'm giving you my lecture from the hospital, which is around here in the background, and I certainly appreciate this opportunity very much, and I also appreciated, of course, my previous visits to Kolkata personally. Now, you'll have to kind of earn your lunch with me, and please bear with me when we are going over the next 20 minutes through the past 24 years of PCI. Now, Ashok, of course, also knows that from his time in Germany. This is the man behind PCI, Andreas Grünzig, a doctor of German origin who, fortunately for our Swiss history of medicine, came to Switzerland to practice and to also finish his boards in internal medicine in about 1969, 1970, is the father of PCI as we know it today. He was born, as you can see, just at the beginning of the Second World War. And as you all know, he died very early in a tragic plane crash. Now, while it is, of course, tragic to have lost him at the young age of 46, it is also kind of unfair because we keep him in our minds as a dashing, good-looking young fellow. And looking at his face very closely, we can only imagine, you know, what the past 41 years would have done to him and what he would possibly look like today. Today, he would be at the age of 79 years. Now, what Andreas Grünzig has done for cardiology is shown in this picture. You know, before Andreas Grünzig, cardiology was basically a poorly diagnostic discipline. Of course, there were good recommendations to give, diagnosis could be made, and also, of course, some medications could be described. But more often than not, with purely diagnostic disciplines, you know, this might have been the reaction of the patient. And with Andreas Grünzig, we all of a sudden, like the surgeons, had something in the hand to repair the disease, to really give some manual help to the patient. And of course, that has, as we all know, complemented the array of possibilities we have in cardiology today. Now, Andreas Grünzig invented many things, not all of them worked. The balloon catheter he invented certainly worked, and I think it is important, particularly for our young colleagues, to know that you really have to believe in what you're doing. And Andreas Grünzig believed in what he was doing. At his age of 40 years, he just wanted to see his coronary arteries. He had no specific symptoms, but he thought that it is a good thing to see my coronary arteries. So he believed in his trade of doing diagnostic angiography. And of course, he also believed in his own child PCI. So if he had needed PCI, he would have had it without any hesitation. And you can see him at the end of his coronary angiogram, quite relaxed. Not quite so relaxed was Hall Whitworth, who was the person doing the catheter procedure. But clearly, this is how much faith he had in what he was also recommending to his patients. And on this picture, you see him just 2 hours after his coronary angiograms going to the party of his apartment. You can see that the pager on man, so he's ready to take night calls. So outpatient coronary angiography was already a thing in 1984. And of course, at the time, this was going through the femoral artery, and I come back to that later. Now, Andreas Grünzig also kind of already defined what we call today the heart team. You may not know, but initially he was not working in the cardiology department, but in the angiology department. This is in Switzerland and Germany, a specialty taking care of peripheral vascular disease, like us cardiologists take care of the heart. So there he developed his balloon angioplasty. It was, of course, a less dangerous field to test the balloons that he was doing. And you can see him here. He was quite the funny person with the balloons ready to work on peripheral patients at the time. Here at his left side, you see his boss at the time, the famous angiologist Fred Bollinger, who today, now in the current heart team, would be the non-invasive cardiologist. To the far left, you see the pathologist who helped him develop his angioplastic catheters. Today in the heart team, that would be the intensive care specialists or the anesthesiologist. And here you can see the vascular surgeon, who today, of course, in the heart team would be the cardiac surgeon. And you can see that Grünzig, who kind of orchestrated this picture, already put the surgeon in the background, and I'm sure the surgeon didn't realize that at the time. Here you can see this famous picture where indeed this is the kitchen stove of Grünzig's home at the time. The catheters that are cooked here in this stove were not coronary balloon catheters, but peripheral balloon catheters, which then were really used after sterilizations in human beings. The coronary balloons, against some saying, were never made in Grünzig's kitchens. At that time already a small Swiss firm was producing the first coronary catheter, which was then also used in the first patient. Here you can see the few dog experiments that preceded the first coronary angioplasty. There were a total of 16 dogs subjected to some preliminary experiments. And you can see that 2 dogs were left to live for 4 weeks to also see the midterm result of balloon angioplasty. And this is one of the initial hearts of a dog in which coronary angioplasty was produced, was sent to pathology for examination. And you can imagine that the response of the pathologist was kind of negative. And in the baseline, what he wrote back is, whatever you have done to this heart, never do it again. But of course, Grünzig was not that easy to be stopped, because at the time he was doing the coronary angioplasty experiments in the dogs, he already had quite some experience in peripheral balloon angioplasty of, for instance, femoral arteries. And so he knew that even in radioscopical or radiographical pictures, that the vessels looked quite dissected at the end of his balloon procedure. And this is what the dog's heart looked like from the inside. So there was bad dissection. After dilating, this fabricated stenosis, it was a ligature by the surgeon that created stenosis, which he then kind of popped with his balloon catheter. But Grünzig already knew from his peripheral clinical experiences that give it some time and there would be some healing. And here you see a dog coronary artery 4 weeks after doing balloon angioplasty. You see that this dissection had healed with some neo-intimal formation. So recurrence was already kind of anticipated, but also it was anticipated that this first dissection of balloon would then heal quite nicely. And here you see the other pioneer of coronary angioplasty, the man at the other end of the catheter, Adolf Bachmann. I can name him because he agrees to being shown, named, and also having his case discussed, because he still is alive, he still is well. He was also 39 years of age on the left side here when the procedure was done by Andreas Grünzig with this original balloon catheter. 40 years on the day later, you can see him here on a picture during a small celebration in Paris on that day. He currently 79 years of age and in quite good shape. And here you can see his story on one picture. This was in 1977 on September 14, when a radiologist of whom the name has been lost in the meantime did this coronary angiogram, and he had a severe LAD stenosis. I had the chance and serendipity let me take care of him at the time as a young doctor. So Grünzig was not in the house on that day. When he came back the next day, I showed him this picture because he and some of his friends were looking for a first case to start coronary angioplasty for many, many months already at the time. And he, of course, immediately said, this is what I need, a fairly proximal single lesion in an otherwise quite healthy person. So 2 days later, he did his first balloon dilatation, and this was the immediate result. Stent-like, as we would call it today. Stents, of course, were not available at the time. It was pre-arranged or pre-agreed to by the patient to have a follow-up angiogram exactly 1 month later. It looked pristine. And exactly 10 years on the day late on September 16, 1987, he had another follow-up angiogram still doing fine, done by Spencer King in Atlanta. Grünzig had already died. He died in 1985 at the time, so he was not able to see that absolute brilliant result here, also done as an outpatient procedure in Atlanta. Things were quite calm and steady for him for 23 years. I did exercise tests on him regularly and he was always fine. He had stopped all his medications shortly after the intervention. He did not believe in medications that were taken for a long time, so he did not quite grasp what preventive medications meant. So no medications for 20 years. He called me and said, I have the same symptoms again that I had before Grünzig did my procedure. You better have a look at it. So April 10, 2000, I did this angiogram, and you can see here that indeed there was a mild restenosis. Grünzig's lesion was actually a bit more distal. It was at the proximal portion of Grünzig's first lesion. Usually I would dilate a lesion like that immediately because there was angina reported by the patient. In this particular case, I did not want to spoil the story of having to redo this case now 23 years later in basically almost the same site. So I sent him home. I said, it doesn't look significant to me. But he kept calling me and saying, I still have angina. I want you to do something. So 5 months later, on September 9, he came back. I did another angiogram, and you can see that basically it looked the same, not much worse. So the only time in my whole life as an intervention cardiology, I did a so-called clinical FFR determination. I never used that for clinical decision making, only for research. But here I did it because I wanted to get out of having to redilate this. And lo and behold, in spite of the angina he had, the FFR was normal, 0.83. So I told the patient, you do not need it. Even in 2000, we already knew that the normal FFR basically meant a non-significant lesion. And so I told him we do not need to do that. It's non-significant. But the patient insisted. He said, I'm here now for the second time, and you don't want to do it? Just do it, as Grünzig did it 23 years ago. So I caved in and I balloon dilated this lesion, and to me it looked okay. But he looked also at the screen, you know, from the table and said, well, today, it was in 2000, everybody gets a stent. I want a stent. So I gave in and I put in a stent, and indeed, as you can see, it did look better. It was a bare metal stent, of course, in 2000. Now he went home and apparently was fine for about 6 weeks when he called me again and told me that now he had symptoms even worse than ever. And of course, I knew what had happened, bare metal stent restenosis. So 2 weeks later, he came back, and as you can see here, he had a severe in-stent restenosis after bare metal stent. This was December 7, 2000. So I just balloon dilated this, and it was good for another 14 years. But at that time, he was kind of puzzled because he said, you did not make any progress in those 23 years. You know, 23 years ago, I had one diagnostic angiogram, then 2 days later, Grünzig did the case, and I was fine for 20 years. Now, 23 years later, I have the same symptoms. I have to come in twice. I have to talk you into doing something. And it's only good for a few weeks, and I have to come back. What progress have you made? Now, as I said, for another 14 years, he was fine again, negative stress test. In 37 years after, in November 6, 2014, he again had symptoms. And of course, coming in for an angiogram, he had another lesion in about the same region. Actually, Grünzig's first lesion, as you can see here on his left side, was just before the diagonal. So it was around here, but my stents, my lesions were about here. So it was a mixture of restenosis, new disease, and so forth. So he had another, this time, of course, a drug-eluting stent implanted there. And ever since, this has been another 4 years, he has been doing fine negative stress tests. Now, Grünzig not only introduced corneangioplasty, he also introduced life courses, which of course you've had many successful ones in Kolkata, into cardiology. Orthopedic surgery already had quite a habit of doing live interventions, kind of shown from the operating room to a lecture hall by TV transmission, but for cardiology, this was new. And his first case, as you could see, was on August 7, 1978. now, of course, has had many successors. And you see that the interest was quite contained from the whole world. 38 patients were interested, only 28 showed up, and the program was quite diversified. You can see here there was an LAD stenosis, PCI, there was a PCI or a peripheral angioplasty of a femoral occlusion shown. There was a coronary bypass graft, PCI shown, and there was an angioplasty shown of a renal artery. So the program was quite interesting already at the time for 28 participants. Now, at that time, until 1979, more than 2 years after angioplasty had been introduced, there was in the entire world only one place where you could buy balloon angioplasties. And you think that this is a very small place, but think again, because that company was working down in the basement. And everybody had to kind of knock at this little window here and show a slip of Grünzig that he or she was, there were no she's then, but he was entitled to buy a balloon angioplasty catheter or two and then pay in cash in Swiss money. Now it's a big industry, as we all know, and it's hard to believe that this was only not even 40 years ago. Now, in the last live course he gave in 1980, before he moved from Switzerland to Atlanta in the United States, he could still jot down the entire world experience in coronary angioplasty on one blackboard. And this is the list. You can see that in Zurich, he had accumulated 170 cases, in the United States, San Francisco and New York, about 100 cases each. And you can see that Atlanta had started with Spencer King, 4 cases, and Asia, India, Far East, Middle East were not yet on the picture here. Of course, you have caught up in the meantime. And these are the 40 years, the first 40 years of PCI coronary angioplasty on a single picture. You can see that the balloon is still king. Actually, it's only become king when it was crowned with the stent in 1986. And you all know that the stent later on started to sweat out drugs, which is the drug-eluting stent, and that is clearly what we still enjoy as the main feature of PCI, king balloon, of course, with a drug-eluting stent crowned. And this has always been in the sunlight. Other things, you know, have come up. Many things have come up, have maybe spent some time in the sunlight, but most of them have returned down back to the cloud. So some of them are nice to have, but none of them is really necessary, and some of them were not even nice to have. There are 2 exceptions. The rotablator is still peeking through the clouds here, and the rotablator is really solving a very rare case where you cannot pass with any sleek balloons, or you can pass, but even at 40 bar, which is the maximal pressure limit of some of the modern balloons, you cannot crack a circumferentially calcified lesion. But that's in a busy center like here in Bern, where we do about 3,000 PCIs a year. We need the rotablator maybe 2 or 3 times a year. And the other thing is probably ECMO. If you have a crash in the cath lab, ECMO can sustain life until you can do something else, but that's only important in very busy cath labs. Now, I'll just have 2 things that you may think are important for coronary angioplasty that I grapple with and do not think that they are really important and should be done in clinical coronary angioplasty. One of them is FFR. I've already alluded to it before in this famous first case. Now, why do I think that FFR should not be used for clinical decision making? You can say that, well, there are so good data. For instance, the FAME2 trial that you all know, it's a 5-year result of randomized patients who first had an FFR done if it was abnormal below 0.8. then they were randomized to either have PCI or just have medical treatment. And as you all know, those who just had medical treatment had a lot of events, particularly, of course, in the first few months, whereas those who had PCI done had a much better course. And this was highly significant, so proving first, of course, as PCI is a good thing, comes as no surprise. You know, the patients came for symptoms. They were randomized to do nothing, and it was quite likely that they would come back for symptoms, which you can see here in this part of the curve. Those who had their symptoms taken care of with PCI, of course, had a much better course. Now, what was misinterpreted, even in the New England Journal, this was not mentioned, is the following. You see that they basically justified that doing PCI was a good thing by the fact that comparing the patients with an abnormal FFR and PCI done were behaving exactly like the patients with a normal FFR in whom nothing was done. They said they didn't need anything, and you can see that those who needed it and had PCI, they had exactly the same fate as those who didn't need anything. But they completely forgot that also though the normal FFR came in for angiography for some reason, so they had some symptoms. Of course, they were lower risk patients because their lesions were not quite so tight yet. But if they had received PCI as well, which I would have done, their course probably would have been something like that. They also would have a significant improvement. And of course, that is the misinterpretation of what the FFR does. It does not help the patient. It does prevent good treatment in some patients. And you may not know, but there is a randomized trials that basically is the nail in the coffin of FFR, but it has not been published yet in a journal. It has been shown twice, one at AHA 2016 and one at ESC Congress 2018. It's the future trial, functional testing underlying revascularization. So here, patients mainly in France planned 1,728 patients were randomized to either have FFR and then only be treated if FFR was positive, was abnormal, or just have an angiogram and be treated by eyeing the angiographic result. And you can see that the study was stopped by the DSMB after about 1,000 studies because of a higher mortality of the FFR-guided arm. And you see 17 patients had died if their PCI was guided by FFR, and only 7 patients had died over the first year if it was just eyeballed, just guided by fluoroscopy. And that was significant, and therefore the DSMB stopped the trial, and the trial cannot be published because of the FFR supporters who apparently give the authors of this trial a very hard time for publishing it. Eventually it will be published somewhere, and actually looking at this trial, you should no longer use FFR as a clinical decision-making tool. And it makes sense, you know, in these patients, you leave behind some lesions that brought the patient in for an angiogram. And if you do not dilate that, there is about a 0.5% risk every year that this lesion will pop up and close the artery and cause a myocardial infarction, maybe even death. If you do PCI with a current drug-eluting stent, the result is so good that you really don't have to fear any problem from that particular lesion in the future. And the cost of doing angioplasty is about the same as the cost of doing FFR. So why not just forget FFR and do angioplasty? So this in a nutshell is how I see that we should use PCI nowadays. And I've learned that from my tutor, Andreas Grünzig, in the beginning. I call that the course of life, or if you blank out the O here, it would be the curse of life. Now, you can show that with any disease, but coronary artery disease is particularly well suited for this metaphorical depiction of how I see disease and life. When we are born, we are cast on this high plane, and we just move ahead and like to stay in the midline, to stay on the plane as long as we can. Someday we will fall off the precipice. Now, if you have a first problem with coronary artery, like our patient at the first patient, very young age, you come dangerously close to the cliff here. But of course, drugs will stabilize the situation for a while, and the PCI of Andreas Grünzig can bring you back to the midline, and then with a little luck, you'll spend the rest of your life in the midline. As you know, that our first patient, of course, had some more some more passages on changing his direction, going in this way here, but then he was brought back again to the center line. Now, the other way, if you go the other way here, of course, you can also have a stable course, and then studies like FAME, Courage, Orbita, etc. will tell you do nothing, because all they're looking at is the patient stable and is the patient alive? Yes, the patient is stable. Yes, the patient is alive. But I'd much rather be stable and alive here in this area than down here, than out here. Because even in the best of all cases, this is how life is going to go on. And of course, if you're unlucky, what is going to happen is you're going to go this way early on because you have an additional disease. And this is really not what you want. So do ignore all these studies and do your PCI, for heaven's sake. Now, just a word before I finish about surgeons and cardiologists. Of course, we have to work together. They're our friends. As you may know, I'm not a particular fan of the heart team, because I think us cardiologists, we know what we can do, we do what we can do, and those cases that we cannot do, we ask our friends surgeons to help us, but we do not to discuss every case with our surgeons, be it for valve replacement or for coronary angioplasty. So this picture is kind of sarcastical, of course. We are in this boat together with the cardiac surgeons, but as you can see, we're not necessarily wanting to go the same direction. But of course, the surgeons still get their cases, because as you can see, somebody with heavy triple vessel disease, calcified left main circumflex, intermediate branch, LAD lesion, right lesions, and good peripheral segments are perfect patients for surgery. If I had this situation, I would go for bypass surgery. I would not want anybody to try PCI. And all the randomized trials have proved that if you push the envelope too far, surgery is better. But even multivessel disease with limited lesions can be done very successfully. So this is now the story of reducing mortality. Because we are working with the heart, people actually expect from us interventional cardiologists to save lives. That's not quite fair, because dermatologists, orthopedic surgeons, ophthalmologists, most internists, they do not primarily work to save lives. They work to get the patient better. So that having less angina should already be a success for us. But working on the heart, showing mortality benefit, of course, is quite nice. And you know that the surgeons, because they are treating the high-risk coronary patients in far advanced disease, they always have quite easily shown that they reduce mortality here, going to the left side of the line of identity. Now with POBA, with Grünzig's initial just balloon without the stent, he was quite close to reducing mortality. But of course, the patients treated did not have a high mortality, because they usually had single or double lesion coronary angiography, so it was more difficult to show mortality reduction. Then it got a bit worse when the stent was introduced. The bare metal stent did solve some problems in the cath lab, but it introduced stent thrombosis. Late thrombosis of the coronary artery was unknown before stents. There were acute thrombosis in the hospital, but once the patient left the hospital, the lesion would not thrombose. It would restenosis, but not thrombose. But with stents, we had those abrupt stent thrombosis, which could kill the patient at home, of course, because it happened after discharge. So bare metal stents were actually making PCI less effective in terms of longevity. Then came the first drug-eluting stents, and we all know that they were actually blamed for being worse than bare metal stents. They never were. They had more late stent thrombosis after the first year, but they had fewer stent thrombosis in the first year. So overall, they had a little less stent thrombosis already the first generations than BMS. So their effect on mortality was certainly not worse than bare metal stents, as we thought for about 10 years, but not much better. And it's only now with the current very, very, very effective drug-eluting stents where we really now can again show, or for the first time actually show, a significant effect on the reduction of mortality, just like our colleagues, the surgeons. Now, let me just finish now with one other thing that I do not support that much. That is the switch now from femoral approach to radial approach. The older ones among us know that we first started through the arm with the Sones technique. Then we were happy with the Amplatzer and also Chutkin's technique to move to the groin, and now we're moving back to the radial artery. And this is like, you know, having been able to ride a bicycle, that's the femoral. We now all of a sudden want to ride a monocycle. It's a bit more intricate, a bit more difficult to learn. You can learn it, everybody can learn it, but do we really have to learn it? Of course, you can deliver pizza on a monocycle if you have learned it. That's okay, but it's much easier to deliver pizza on the old bicycle, which is much easier to ride. Particularly if the terrain gets difficult, like here, it's much easier to be on a bicycle than be on a monocycle. But in contrast to these riders here who take their own risk, you know, when we are changing, everybody's changing for all cases from femoral to radial, we're not, paying for our falls and crashes in the longer learning curve. It is the patient who pays for these falls and crashes in the longer learning curve of everybody, and that's not just. Moreover, this switch is actually based on a wrong interpretation of a study. You all know the Matrix study showed some better outcome data if acute patients were done radially rather than femorally. But these were acute patients, but we're doing it now in every patient first. Second, you can see that even this matrix trial was only positive when you were looking at the radial centers in the trial, because they were trying to push their radial. They were kind of, they were displeased because nobody followed their radial habit. Particularly the French centers, Italian centers had done radials for 20 years and no heads turned. So they came up with this study and showed that in their centers it was really better. In the centers who were actually not radial centers or were doing both but more femorals, actually there was no difference here. Even the femoral was numerically better than the radial. So this was just kind of propaganda of radial centers, pushing now everybody to do radials. And we are not telling the patient, and we should, because the risk is 2 to 30% that they might lose their radial artery because we are doing our cath through the radial artery. They will never lose the femoral artery, but they might lose the radial artery. It may not be 30% as shown here, but it's probably not 2.3% either. It's somewhere in between. And we should not forget that the radial artery cannot be used as a bypass, or should not be used as a bypass later. Now we get all these meta-analysis showing that radial artery bypasses are good. Personally, I admit I doubt it. I would not want the radial bypass myself. I would But anyhow, you cannot use them, and the patient certainly doesn't want to lose his radial artery if he can avoid that. And just this week, in Czech, we saw the Spirit of Artemis trial, which showed that yes, you can actually decrease the risk of radial occlusion if you just double your heparin dose from 50 per kilo to 100 units per kilo. Now, looking at this trial, which was a randomized trial in 3,000 patients, of course, you should keep in mind what we always keep in mind when we look at trials. Of course, the old dose of heparin is made look worse than it really is, and the new dose, which they want to advance, of course, with this trial, is going to make look better than it really is. So the real occlusion risk is probably somewhere in between here at about 5%. And of course, you can decrease it by using a bit more heparin, but this risk is still there. And if we tell the patient that he or she has a 5% risk of losing the artery because we're going radial, patient may not want it. So let me just finish up showing that, yes, we started invasive cardiology in 1929 with Forsman self-experiment, and it looked at that time our stethoscope turned into this kind of a stethoscope. Then Grünzig gave us interventional cardiology, and our stethoscope started to look like this. Then, of course, in 1986, the stent came in, and we moved from interventional to interstitial cardiology, and our emblems looked like this. Then drug-eluting stents came about, and I doubt that we will go any further. So, of course, kind of heart transplantation by injecting new cells here would be nice, but I do not think that this will ever be possible. And neither do I think that what is coming up again, this kind of automated PCI, like surgeons are doing from a joystick here, doing our PCI will ever be done, because you still have to kind of introduce the catheters yourself. Would be a good thing because you can stay out of the X-ray room, but it will probably not happen like this dentist, who just makes the diagnosis, then, programs his computer and then sits back and reads the newspaper while the computer is doing the therapy. We're not going to have that. Unfortunately, it would be nice, but it's not going to happen. So my last slide here shows, the palmarès or the list of what has happened in interventional cardiology. We think it started with Grünzig. Not quite true, because as you can see, even coronary interventions had been done. 1972 in Brazil, somebody recanalized, or Galeano recanalized an acutely occluded coronary artery by just pushing a guide wire down, and then he had flow again. But certainly, Grünzig's PCI kind of was the start of what we call interventional cardiology. You see some other coronary procedures were proposed, but the only really important one was the introduction of the coronary stent, 1986 in France by Jacques Puel, who is no longer with us. But there are spin-offs, and the most important spin-off certainly is TAVR, transaortic or transcatheter aortic valve replacement or implantation. And of course, mitral valve, another very common disease, is not yet quite ready for prime time, but it certainly will be. And I think if we hadn't had PCI, if we hadn't had Grünzig, we would not have these very, very important spin-offs nowadays. Thank you very much.
Thank you, Professor Meyer, for your fascinating and thought-provoking speech. I remember about the boat journey with Madam Meyer and yourself and some of us, and we have been learning from you the beautiful journey you have started with Andrew Grünzig in 1977. And thank you also for your fascinating analysis of the data of the guidelines as has been depicted by the future trial presentation in Munich 2 months back, and also of the critical analysis of the radial versus femoral. So it's a fascinating journey, and we have been learning from your masterly speeches for the last several years, and thank you very much again for being with us this year also, and we really appreciate it. For Dr. Dhar, any comments?
And thank you very much. You have not only brought along science, but very interesting facts about percutaneous interventions all along. A number of them are totally new to us, and it's very interesting. And a different look at what we perceive to be science is also very interesting. So I we really enjoyed this lecture, and we hope we keep on seeing you year by year, having some new information, new data analysis, and new insights into percutaneous interventions. Thank you very much for your nice talk.
Bernie, Ashok here again. Thank you very much that you agreed to share your time with us and our audience here. They have really learned some newer things, and we all thank you very much. Unfortunately, we are running a little late, so from audience participation will not be possible today, but we hope to see you soon again, and you are always welcome here. Thank you.
Well, thank you, Ashok. And I also would like to thank Ushal in the back. He's the technician who made this possible. And I'm really sorry I delayed your lunch. And I thank you for having me from Switzerland.
Thank you. Thank you, Dr. Berhard Mayer, for your web lecture, and thanks a lot to all our chairpersons, Dr. Ashok Dhar, Dr. Anil Mishra, and Dr. Dhiman Kahali. Thanks a lot.